Welcome to the module on adult sarcomas. I am Dr. Janelle Mann, Manager of Clinical Pharmacy Services and Clinical Oncology Pharmacist at the Alvin J. Siteman Cancer Center, Washington University School of Medicine in St. Louis, Missouri. This presentation is part of the ASHP ACCP Oncology Pharmacy Specialty Review course, which is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. The activity is designed to be interactive with questions posed to you at several points. I will pause to allow you time to consider how you would answer the question. You may wish to write down your answers and the correct response in your handout.
The disclosures are displayed on this slide. You will find the learning objectives for this presentation on this slide. We will start with a patient case. JR is a 38-year-old female that's undergone a successful resection of a 3-centimeter intestinal gastrointestinal stromal tumor, also known as GIST. The pathology indicates that the tumor is c-KIT positive, found with exon 9 mutation, and had 4 mitoses per 50 high power field. What is the most appropriate treatment for JR at this time? Is it A, imatinib for 1 year, B, imatinib for 3 years, C, Avapritinib for 1 year, or D, sunitinib for 3 years? All right, so the most appropriate answer would be A, imatinib for 1 year. JR should be treated with this therapy of imatinib for a year as she has low risk for recurrence due to the size of her intestinal tumor and the mitoses rate being less than or equal to 5 per 50 high power field. She is also c-KIT positive. Sunitinib and Avapritinib would not be appropriate to recommend as they are only approved in the metastatic setting at this time. And if she had had high risk features such as a larger tumor size or greater than 5 mitoses per 50 high power field, the duration of that adjuvant imatinib therapy would be 3 years over the 1 year, which was recommended for this patient. Sarcomas are a diverse group of rare mesenchymally derived tumors. Most risk factors or even specific etiologies are unknown. More common in adults to develop soft tissue sarcomas over that of osteosarcomas. Additionally, poor prognosis has been identified in patients with age greater than 60, tumors greater than 5 centimeters, and a high-grade histology. As you'll learn, a multidisciplinary management approach is recommended for this patient population. In our patient case earlier, JR was found to have a GIST tumor, which is one of the most common soft tissue sarcomas that's observed in the GI tract. What you're going to also identify is that often GIST tumors, nearly 85 to 90% of them, have expression of KIT. And this is important because many of our therapy selections are going to be derived towards targeting KIT. However, what we do need to know is that KIT is very complex, and it's important to also know the specific exon mutations, as you can find some in a more common domain. So KIT exon 11 mutations are the most commonly observed in GIST tumors. You will find in intestinal GIST exon 9 mutations within KIT. PDGFRA mutations do arise in about 5 to 10% of patients with GIST, and it is fairly common to see it in exon 18 and more specifically in those of the gastric domain. 10 to 15% of GIST do not have a detectable mutation, however, in KIT or PDGFRA, also known as wild-type GIST. And these GIST tumors are poorly responsive to cytotoxic chemotherapy and radiation therapy. So as I alluded to, therapies that target KIT are going to be incredibly important for these patients. After completion of surgical resection, we evaluate the risk of relapse using the following prognostic factors. Ultimately, location of their GIST tumor and size of that tumor play a role as to determining their later risk of relapse, along with their mitosis rate. KIT mutational status is not used to determine the malignant potential, but it is predictive in response to the tyrosine kinase therapy that's recommended. The role of preoperative imatinib therapy is not well defined. However, in the postoperative setting, a phase 3 trial with imatinib at 400 milligrams daily compared to placebo for 1 year did show an improvement in recurrence-free survival at 98% with imatinib over that of placebo. And this ultimately defined the role for adjuvant imatinib therapy. In the adjuvant setting, the debate often is how long to treat. So a phase 3 trial of nearly 400 patients with high risk of tumor recurrence were randomized to receive imatinib for 1 year versus imatinib for 3 years. And ultimately, this particular trial demonstrated that 3 years of imatinib therapy improved the 5-year overall survival rate at 93.4% compared to 86.8% for 1 year. This trial established imatinib in the adjuvant setting for 3 years as standard of care in patients with high risk of tumor recurrence. While in the adjuvant setting, we didn't necessarily need to know more than just a patient's KIT positive status, you will find in the metastatic setting that this additional mutation analysis can be very important as it can predict outcomes to treatment with imatinib therapy. And this was observed in a phase 3 trial where they actually found that patients who had exon 11 mutation versus exon 9 mutation, and even those with wild type mutations, that ultimately their response to imatinib varied. You'll see that the overall survival was found to be much shorter in the exon 9 mutation, which makes us think that imatinib is not as responsive for exon 9 mutations and may warrant an actual dose increase to 400 milligrams twice a day. However, these higher doses of imatinib do lead to greater GI toxicities, so it's important to provide education to patients and determine the most appropriate option based on the patient-provider discussion. Additionally, we will see that this particular response was found in these patients that are exon 9 mutated, and use of 800 milligrams would be recommended following an initial start of 400 milligrams daily. First-line treatment for unresectable, recurrent, or metastatic GIST includes imatinib, which has been the mainstay and Category 1 recommendation for many years. More recently this year, Avapritinib, a new drug, hit the market and is available for patients with GIST that have a PDGFRA exon 18 mutation, and also those that have a PDGFRA D842V mutation, which is known to be overly resistant to imatinib. NCCN lists this as a Category 2A recommendation in the first-line setting. The NAVIGATOR trial was a phase 1 trial. Its design was two-part, looking at dose escalation in Part 1 and dose expansion in Part 2. As highlighted on the slide, the patient population included unresectable GIST after progression on imatinib and at least one other tyrosine kinase inhibitor. It also recruited PDGFRA D842V mutant GIST patients. The primary endpoints of this particular trial were to identify the maximum tolerated dose, the recommended phase 2 dose, safety and dose escalation parts, and overall response and safety in the dose expansion. In the dose expansion phase, the Avapritinib dose was 300 milligrams by mouth daily. At data cutoff, 46% of patients in the safety population remained on treatment with a median follow-up of 19.1 months. 66% of patients with that PDGFR D842V mutation remained on treatment with a median follow-up of 15.9 months. The maximum tolerated dose identified was 400 milligrams by mouth daily. What was pursued as the recommended phase 2 dose was 300 milligrams by mouth daily. 57% of patients did develop grade 3 or 4 events, and 17% of them demonstrated anemia. In the PDGFRA D842V patient population, 88% had an overall response. Of note, 9 of those had a complete response, and 79% developed a partial response. Avapritinib was ultimately FDA approved for unresectable or metastatic GIST harboring that specific PDGFR exon 18 mutation including those with the very resistant mutation D842V. The dosing, as highlighted before, is 300 milligrams by mouth daily on an empty stomach. Toxicities that were commonly reported included edema, nausea, diarrhea, decreased appetite, cognitive impairment, which was further described in the package labeling as related to dizziness, sleep disorders, mood disorders. The median onset observed with the first CNS adverse effect was 6.1 weeks, and depending on the severity, holding therapy and resuming at a lower dose may be warranted. Furthermore, a rare but serious adverse effect was observed, which included intracranial or cerebral hemorrhage at a rate of 1%. So as you would expect, acquired drug resistance is usually the result of secondary imatinib-resistant mutations in KIT or PDGFRA, and so subsequent therapy and treatments are important to describe. The NCCN guidelines recommend in second-line treatment for GIST patients sunitinib, based on data supporting it to improving tumor progression at 6.3 months with sunitinib versus 1.5 months compared to placebo. Following that, third-line data with regorafenib demonstrated a progression-free survival improvement at 4.8 months compared to 0.9 months with placebo, making this a preferred NCCN recommendation for third-line treatment in GIST patients. Prior to this year, patients that had progressed past regorafenib really would be offered clinical trials, which are still important, but I will highlight that this year we have yet another agent approved in the setting of GIST patients, and it is ripretinib. Ripretinib was approved based on the Invictus trial, which was a phase 3 randomized placebo-controlled trial evaluating the effectiveness of ripretinib compared to placebo. The median progression-free survival was 6.3 months with ripretinib versus 1 month with placebo, which seems to mirror prior data with sunitinib and regorafenib. As well, important to notice, however, was the improvement in overall survival with 15.1 months with ripretinib compared to 6.6 months with placebo. The FDA approved this agent for advanced GIST patients who had received prior treatment with 3 or more kinase inhibitors, including imatinib, and it's dosed at 150 milligrams, which would be 3 50-milligram tablets by mouth daily without regard to food. It is a major substrate of CYP3A, and it's recommended to avoid concomitant use of strong CYP3A inducers. Package labeling does recommend holding or dose reducing for significant toxicities, which included arthralgias, myalgias, hypertension, left ventricular ejection fraction dysfunction, as well as rash. Common adverse effects that were reported included alopecia, fatigue, nausea, constipation, and vomiting. Grade 3 or 4 lab abnormalities with increased lipase and decreased phosphate occurred in approximately 4% of patients. Last, to highlight, rare toxicities did occur, which included new primary cutaneous malignancies, so it is recommended to perform a dermatologic evaluation when initiating therapy and routinely during treatment. But the addition of ripretinib really did change the treatment pathway for patients following progression off what would at this point had been 3 prior tyrosine kinase inhibitors. So in summary, for unresectable metastatic GIST, the first-line treatment options as Category 1 NCCN recommendations would be imatinib. For Category 2A recommendations, avapritinib in those patients that have that unique PDGFRA mutation. Those that progress on first-line therapy are offered then sunitinib in the second-line setting, regorafenib in the third-line setting, and now ripretinib in the fourth-line setting. Of note, avapritinib was studied in a phase 3 open-label randomized trial, which compared avapritinib to regorafenib in those patients that were previously treated with imatinib and 1 or 2 other tyrosine kinase inhibitors. This was the Voyager trial. The results of this study prevented the addition of fourth-line indication for avapritinib. However, the presence of certain KIT-resistant mutations may make it more desirable in select cases. Epithelioid sarcoma is another rare, less than 1% of all soft tissue sarcomas, that is identified to be very aggressive, locally invasive, and frequently metastasized. In its overall patient population, younger males are most at risk or have the most prevalence of developing this sarcoma. It presents as a painless, small lump in the soft tissue of the hand, forearm, or lower leg. Important to note, there are some genetic characterization of having either inactivation, deletion, or mutation of INI1. Management is similar to other soft tissue sarcomas, where early stage disease, it is recommended to have complete surgical resection. However, it's important to note it does come with a high recurrence rate and distant metastatic risk. Due to this, Tazemetostat was evaluated as a single-arm cohort in study EZH202. It enrolled patients with metastatic or locally advanced epithelioid sarcoma with INI1 loss and a good performance status. They evaluated tazemetostat at 800 milligrams by mouth twice daily. The observed objective response rate was 15%, with 13% of those developing a partial response. Tazemetostat is a selective tyrosine kinase inhibitor against EZH2, which is linked to that INI loss. Indications for this FDA-approved drug is adult and pediatric patients greater than 16 years of age with metastatic or locally advanced epithelioid sarcoma that were not eligible for complete resection. The dosing was described in the prior slide, but it's 800 milligrams by mouth twice daily. Toxicities observed included pain, fatigue, nausea, decreased appetite, vomiting, as well as constipation. You may require dose holds and modifications for patients that develop neutropenia, thrombocytopenia, as well as anemia. And additionally important to recognize, co-administration of tazemetostat with strong and moderate CYP3A inhibitors and inducers will ultimately be recommended to be avoided. Another unique subtype of soft tissue sarcoma is tenosynovial giant cell tumor. It is a locally aggressive tumor that arises in the synovium of joints, bursa, and tendon sheaths. Again, surgery is a standard treatment. However, recurrence is very common. Pexidartinib was approved for symptomatic TGCT, which was associated with severe morbidity or functional limitations and are not amendable to surgery. This was given NCCN preferred category 1 recommendations. Pexidartinib is dosed at 400 milligrams by mouth twice daily on an empty stomach. It does come with a black box warning for hepatotoxicity. Additional toxicities included elevated LDH, hair color changes, neutropenia, lymphopenia, orbital edema, and also the main reason for discussing pexidartinib is the fact it comes with a REMS program, which has limited specialty pharmacy distribution. Providers and patients must be enrolled in the REMS program, and pharmacies must be certified with the program and assure that prior to dispensing, the patient has been authorized for treatment. Moving on to a patient case. WJ is a 45-year-old male who presented with a gnawing pain in his left thigh. He can feel a knot that he claims has grown over the past several months. A core needle biopsy did reveal a high-grade synovial sarcoma. He has no significant comorbidities and is in a good performance status overall with an ECOG of 0. Unfortunately, surgery was incomplete with positive margins, and WJ undergoes adjuvant radiation therapy, and the multidisciplinary team recommends chemotherapy and has asked you to counsel him in the room. Which chemotherapeutic agents would be considered as part of WJ's adjuvant regimen for synovial sarcoma? A, gemcitabine and docetaxel, B, regorafenib, C, ifosfamide and doxorubicin, or D, doxorubicin. The most appropriate answer for this patient's adjuvant regimen would be ifosfamide and doxorubicin, option C. Data with chemotherapy agents for synovial sarcoma demonstrate improved outcomes when giving doxorubicin in combination with ifosfamide. And it is important to realize that we use the histology of soft tissue sarcomas to better derive a more appropriate chemotherapy combination or recommendation. Doxorubicin as a single agent did not necessarily demonstrate a statistically significant improvement in outcomes based on a 2008 meta-analysis. And regorafenib, while targeted therapies are being evaluated, would not be appropriate at this time. Soft tissue sarcoma has many modalities of treatment, that including surgery, radiation, chemotherapy, and even targeted therapy. Surgery, however, is often the most important and is curative in intent and the cornerstone of therapy. Radiation and chemotherapy both have been evaluated in the preoperative, postoperative, and metastatic setting. As you can imagine, if surgery is the mainstay of treatment and really the best option for curative intent, having functional and appropriate limb-sparing procedures would be ideal for patients. Again, though, our goal is to get complete tumor removal, which is greater than 2 centimeter margins. At times, this can be quite difficult, and that is where we see adjuvant modalities utilized. Radiation therapy is most commonly combined with surgery and can be done in the preoperative or postoperative setting. However, it is important to realize that data exists demonstrating that preoperative radiation did lead to a 35% wound complication rate, and ultimately, in comparison to those with a 17% wound complication rate for those that did not receive preoperative radiation therapy. So we do tend to use this in a more postoperative setting to reduce that wound complication portion of patient treatment. Surgery and radiation was evaluated through a 2018 meta-analysis of nearly 4,000 patients where they looked at external beam radiation versus those with no radiation for resectable soft tissue sarcoma. What was found is that there was reduced local recurrence and improved overall survival for retroperitoneal soft tissue sarcoma, as well as reduced local recurrence for soft tissue sarcoma of the extremities, head and neck, or trunk wall. The local recurrence rates were lower with preoperative radiation than that with postoperative radiation, specifically for those retroperitoneal soft tissue sarcomas. But as I highlighted in the prior slide, it's important to recognize that wound complication rates were still pretty significant, and that needs to be weighed in the discussion of whether radiation is used upfront prior to surgery. So chemotherapy is an area of discussion as soft tissue sarcoma isn't necessarily highly responsive to cytotoxic chemotherapy. It's really imperative that we select appropriate agents based on the patient's sarcoma subtype or histology. And really not knowing that histology can drive you down a path of possibly selecting inappropriate regimens. Chemotherapy is not well defined for sarcomas other than those with rhabdomyosarcoma, osteosarcoma, and Ewing's sarcoma. Chemotherapy in the neoadjuvant setting versus definitive local treatment, aka surgery, is still unclear. The neoadjuvant therapy in this randomized prospective trial of 150 patients evaluated local treatment, which was surgery, versus neoadjuvant chemotherapy with doxorubicin and ifosfamide, followed by surgical resection or definitive treatment. The 5-year disease-free survival was 52% for local treatment compared to 56% with chemo and local treatment. Furthermore, we started to evaluate whether the histology played a role. So a study looking at histotype-tailored chemotherapy in the neoadjuvant setting as a phase 3 trial with accrual of roughly 287 patients. The goal was to receive 3 cycles of epirubicin with ifosfamide versus histo-tailored treatment, which would have been possibly gemcitabine and dacarbazine for leiomyosarcoma, ifosfamide for synovial sarcoma, and others, following then by definitive local treatment. The median follow-up was 12.3 months, and unfortunately the study was closed early for futility. The projected disease-free survival was 46 months was 62% for standard chemo versus 38% in histotype-tailored treatment. What this told us is, unfortunately, we were unable to discern whether histotype-tailored treatment was really the best strategy to take, as it was unable to meet power. But it did end up resulting in understanding that it's unclear who would actually benefit from neoadjuvant chemotherapy. Chemotherapy was then evaluated in the adjuvant setting, and the Medical Research Council meta-analysis showed significant improvement in local and distant recurrence-free survival and trends towards overall survival benefit. And this was based on a meta-analysis of 14 trials containing doxorubicin. The multiple agents, unfortunately, used in this 14 trials, it was unclear to discern the clear benefit. In 2008, this was updated and included 4 additional trials. What it did identify for us, though, is that there was improvement with doxorubicin combined with ifosfamide in favor of chemotherapy for overall survival, with an absolute risk reduction in death of 11%. So it did highlight that doxorubicin is active, and for select patients, the combination of doxorubicin with ifosfamide might be beneficial. In clinical practice, the discussion for adjuvant chemotherapy is still very much a patient-provider discussion, as the toxicity data and individual patient factors may lead to additional risk for the patient. So at this point in time, there's no proven role for adjuvant chemotherapy. However, in practice, if you were to utilize a chemotherapy-based regimen, you would definitely want to include a doxorubicin plus or minus ifosfamide combination. On to metastatic disease. Only about 10% of soft tissue sarcomas will present with metastatic disease. So for many patients, surgical cure is a definitive option. It is important to note, however, that about 50% of patients will have relapse of their disease at a distant site. Doublet therapy has a higher response rate. However, not all combinations improve survival. On the slide, you'll note additional favorable response criteria, and many of them make sense based on tolerability of chemotherapy in this patient population. Doxorubicin is considered to be the most active agent and is NCCN preferred first line for metastatic disease. It was found based on a phase 3 trial which compared doxorubicin to doxorubicin intensified with ifosfamide. There was no difference in overall survival. The median progression-free survival was significantly higher with the doxorubicin and ifosfamide group, and higher objective response rate and toxicity in the doxorubicin and ifosfamide arm. So while doxorubicin single agent is very active, in select patients, the use of combination may be beneficial. So what do we do for patients who can't tolerate doxorubicin-based chemotherapy? The GETIS trial demonstrated, when comparing doxorubicin versus gemcitabine and docetaxel, that the overall proportion of patients alive and progression-free survival at 24 weeks were nearly identical. So it did allow us to give an option for an anthracycline-free regimen for patients with metastatic soft tissue sarcoma. To highlight the anthracyclines that are used in soft tissue sarcoma, you may see doxorubicin most predominantly. There was a trial comparing pegylated liposomal doxorubicin to that of doxorubicin, and ultimately showed no difference in activity. Additionally, epirubicin has also been evaluated in soft tissue sarcomas. The response rates listed here share similar rates. However, doxorubicin in clinical practice is most predominantly used. In soft tissue sarcoma, the fixed dose rate gemcitabine recommendation has really stayed strong within this disease group. Instead of infusing the dose over 30 minutes, what they utilized in the clinical trials was a 10 milligram per meter squared per minute recommendation. The theory was that prolonging that infusion rate would increase the amount of active triphosphate metabolite, which would then increase efficacy. That increased efficacy has not actually been proven, but since studied this way, it's still being used in practice. So important to recognize that the infusion time might be different for gemcitabine in soft tissue sarcoma. Additional combination chemotherapy regimens are available on this slide. You may encounter the use of AIM, which would be doxorubicin in combination with ifosfamide. Always remember that M with ifosfamide is the use of Mesna, which is an important supportive care therapy. It did show a response rate of 26%. Additionally, doxorubicin and dacarbazine has been evaluated with a pretty good response rate of nearly 17%. As we discussed, that soft tissue sarcoma does show that maybe histology-based therapies to be more effective. The gemcitabine docetaxel combination did show an improved response rate of 53% in specifically leiomyosarcoma, so you might encounter that more prevalently in that patient population. We do have data as well just for ifosfamide single agent with a 19% response rate. Moving on to second-line therapy. In the second-line setting, Eribulin is approved for advanced liposarcoma, and this was compared to dacarbazine. There was an improvement in overall survival, and when you look at the subset analysis, the liposarcoma patient population really drove that overall survival improvement at 15.6 months with Eribulin compared to dacarbazine of 8.4 months. The leiomyosarcoma subset, however, did not demonstrate that same improvement, so the indication by the FDA is limited to patients with liposarcoma. Additionally, in the second line and beyond setting for soft tissue sarcoma, Trabectedin is approved for those with refractory advanced liposarcoma and leiomyosarcoma. Trabectedin was infused over 24 hours, so it does require a central line, and this was studied against dacarbazine. It does come with significant toxicities. Notably, Trabectedin was found to have high rates of hepatotoxicity, rhabdomyolysis, as well as myelosuppression, and patients often require prophylactic growth factors to reduce their myelosuppression that was observed. When looking at soft tissue sarcoma, Olaratumab and Doxorubicin may be in some of the reviews, but I do want to highlight that the FDA at this point is recommending no new patients receive Olaratumab outside of a clinical trial, and NCCN has removed its endorsement, as during the phase 3 announced trial completed in January of 2019, it did not meet its primary endpoint to improve overall survival. To round out the second line setting, it's important to realize that there is at least one oral agent available for patients with advanced soft tissue sarcoma, and this is approved. Pazopanib has been found to be effective in non-liposarcoma patients. They allowed patients to enroll in the trial after failing a prior anthracycline-based chemotherapy. The median progression-free survival was 4.6 months with Pazopanib versus 1.6 months of placebo, which was statistically significant and did allow for the FDA approval in this setting. So as you have learned throughout the discussion of soft tissue sarcoma, histology subtyping is incredibly helpful as it relates to delineation of chemotherapy agents to recommend. This slide really just highlights the different chemotherapy active agents and the response rates observed. In summary, for soft tissue sarcoma, the use of chemotherapy in the adjuvant and neoadjuvant setting is still somewhat debated, but if regimens were to be recommended, the combination of doxorubicin with ifosfamide or ifosfamide with epirubicin would be appropriate based on NCCN recommendations. In the first line setting, for those with advanced or metastatic soft tissue sarcoma, an anthracycline-based regimen again would be most appropriate. And for select patients that may be able to tolerate combinations such as doxorubicin with ifosfamide or epirubicin with ifosfamide would be reasonable if they have a good performance status. Subsequent lines of therapy for patients with advanced or metastatic disease would include Eribulin, again, category 1 recommendation for liposarcoma patients, Pazopanib for our non-liposarcoma patient population, and then Trabectedin, which is approved or category 1 for liposarcoma and leiomyosarcoma. PL is a 55-year-old male with synovial sarcoma who's scheduled to start ifosfamide and doxorubicin. His regimen's provided there for you. What supportive care is recommended for PL's chemotherapy? Is it A, Mesna at 500 milligram per meter squared IV in 3 divided doses? Is it B, Mesna 500 milligram per meter squared PO in 3 divided doses in addition to hydration with normal saline? Is it C, Mesna 500 milligram per meter squared IV in 3 divided doses given with hydration of normal saline? Or D, hydration with sodium bicarbonate? The most appropriate answer would be C. Ifosfamide-based therapy should always include Mesna as well as aggressive hydration with normal saline. The addition of sodium bicarbonate to the fluids has not been shown to provide any additional urothelial protection. Mesna dosing does vary and can range from 60 to 100% of the ifosfamide dose. However, important to note that oral Mesna tablets are 50% bioavailable, which would make option B wrong as the dose would need to be doubled if given as the oral formulation. Considerations with ifosfamide treatment should include hemorrhagic cystitis risk, and this is due to the metabolite acrolein that accumulates in the bladder. This particular product requires the use of Mesna, which is available both as an IV and oral formulation. Again, as highlighted in the prior slide, multiple schedules for administration do exist. However, it is important to realize they are not a one-to-one conversion. To reduce hemorrhagic cystitis, it is additionally recommended to give vigorous hydration with normal saline and ultimately improving patients' oral intake of fluids for many days after treatment. An additional consideration with ifosfamide therapy is the risk of encephalopathy or neurotoxicity. The presenting symptoms are honestly highly variable and reversible, but important to recognize that confusion, somnolence, hallucinations have all been reported with ifosfamide. Risk factors that have been identified through retrospective reviews include evaluation of the dose of ifosfamide, renal and hepatic dysfunction, low albumin levels, rapid infusions, and previous cisplatin use. If a patient presents with these symptoms, it is recommended to stop that infusion. There are case reports suggesting the possibility of using methylene blue as a prophylactic or treatment option. In 2020, the ESMO guidelines actually did not recommend the use of methylene blue, thiamine, and or glucose 5% for prophylaxis or treatment. So ultimately, patients presenting with these symptoms, it's highly recommended to stop the infusion, and hopefully time will improve their overall cognition, and evaluation of future therapy should be considered. Our next case is TB, who's a 34-year-old male presenting with left knee pain that continues to be persistent and intermittent since falling at a soccer game. His primary care doctor recommends radiographic imaging of his knee. On review of imaging, it did demonstrate a lytic lesion in the left tibia, approximately 4 centimeters. The MRI showed a defined area of marrow replacement by that lesion, and such an open biopsy was performed, revealing the diagnosis of high-grade osteosarcoma. TB is planned to undergo neoadjuvant chemotherapy followed by surgery. Which of the following chemotherapeutic regimens is most appropriate? A, high-dose methotrexate, cisplatin, and doxorubicin. B, high-dose methotrexate, cisplatin, and ifosfamide. C, cyclophosphamide and topotecan. Or D, regorafenib. TB should receive chemotherapy with high-dose methotrexate, cisplatin, and doxorubicin. Doxorubicin and cisplatin are typical agents with or without high-dose methotrexate. There has been evidence looking at the use of ifosfamide in this combination. However, this does increase one's toxicities, but has not been shown to be superior to methotrexate, cisplatin, and doxorubicin combination chemo. Regorafenib and cyclophosphamide plus topotecan would be considered options for recurrence based on additional patient characteristics. Sarcomas of bone are defined by local growth and invasion. Local recurrence correlates with inadequate surgical removal. Recurrence usually occurs within 24 months of surgery in 95% of patients. Distant metastases develop later in the disease course, and 80% of patients develop metastases post-surgery if they did not receive adjuvant therapy. Prognosis of osteosarcoma is driven by many factors, including not only tumor site and size, as well as tumor necrosis following preoperative chemotherapy, their primary metastases identified at diagnosis, completeness of the surgical resection, as well as patients diagnosed at an age greater than 40. When evaluating the role of surgery and radiation in osteosarcoma treatment, surgery really has the mainstay here. Looking for limb-sparing procedures for extremities, as well as possibly reserving amputation when patients have gained functional independence from prosthesis or when limb-sparing procedures are precluded. Radiation, however, is limited in use. Chemotherapy, however, does improve cure rate with surgery, upwards of 75%. Active agents are listed there, and ultimately combination therapy is recommended. NCCN prefers cisplatin plus doxorubicin with or without methotrexate. 2 drugs from the previous list above are active agents based on published regimens and may be substituted. The addition of ifosfamide and etoposide increases response, but does not actually improve overall survival. What we typically see for patients in our practice, we start with neoadjuvant therapy for 1 to 2 cycles and then evaluate for surgery. and if appropriate, send to surgery with plans for the remaining 4 cycles of chemotherapy to be administered in the adjuvant setting. The response observed within that pathology after surgical resection is important, as if we do see a good histologic response, we can continue with the same adjuvant chemotherapy. However, if there is a poor histologic response, we may adjust our plan and recommend more intensive therapy. On this slide is an example of one of the regimens. The key here is, unfortunately, they're very complicated. You will note that the methotrexate and doxorubicin and cisplatin land on different weeks or different days, and so following this regimen can be very complex. This is an additional example of the complexity of these regimens. Again, to highlight, use of high-dose methotrexate does come with significant supportive care recommendations with leucovorin and monitoring of methotrexate levels. In patients who have progression after first-line therapy, SARC-24 demonstrated that an oral agent, regorafenib, at 160 milligrams daily for 3 weeks with 1 week off, would improve patients' progression-free survival from 3.6 months to 1.7 months. Additionally, the median overall survival observed was 11.1 months versus 13.4 months. 10 patients, however, did cross over to active drug at the time of progression. Currently, NCCN recommends regorafenib in the second-line setting as a Category 1 recommendation. In summary, osteosarcoma first-line treatment should contain cisplatin and doxorubicin plus or minus high-dose methotrexate. Second-line therapy options are listed below. The one Category 1 recommendation agent is regorafenib at this time. So after TB received high-dose methotrexate at 12,000 milligram per meter squared over 4 hours, the 48-hour methotrexate level was 5.1 micromoles per liter. His baseline serum creatinine was 0.9 milligrams per deciliter and had increased to 1.2 milligrams per deciliter when that methotrexate level was collected. What is the most appropriate treatment recommendation at this time? A, increase leucovorin. B, start glucarpidase. C, increase sodium bicarbonate infusion to obtain a urine pH of greater than 8. Or D, start desresoxane. All right, so the most appropriate answer would be to increase the leucovorin. Glucarpidase would not be considered yet in this patient, as their current serum creatinine compared to baseline has not elevated to a degree where renal toxicity is of concern. Increasing the leucovorin dose is necessary to prevent toxicity, as the patient's 48-hour methotrexate level was greater than 5 and would be most appropriate to address at this time. Increasing sodium bicarbonate is an option, but this change alone without increasing leucovorin will not effectively reduce the patient's methotrexate level in a timely enough manner given their current methotrexate level. And desresoxane does not have a role in improving methotrexate clearance. So considerations with high-dose methotrexate therapy. It's important to realize methotrexate clearance is logarithmic. High-dose therapy does require leucovorin rescue. Otherwise, it would ultimately be lethal. Utilization of leucovorin until methotrexate levels are less than 0.1 micromoles per liter is often recommended, but institutions often have specific guidelines. The leucovorin generally starts at 15 milligram per meter squared, but will require adjustment based on that methotrexate level. Consideration for glucarpidase for treatment in a toxic methotrexate level situation is important with evidence of new renal dysfunction. Renal tubular necrosis is not prevented by leucovorin, so it is recommended for vigorous hydration as well as alkalination of the urine. Avoidance of NSAIDs, PPIs, and penicillins are often recommended in much of the consensus guidelines. There are consensus guidelines for glucarpidase utilization. It is important to think about what infusion time your methotrexate is, whether it's a 24 to 42-hour infusion or a shorter infusion of less than 6 hours, as the predicted methotrexate clearance and time points would be different, as well as evaluation of serum creatinine and whether or not glucarpidase would be indicated. So in summary, sarcomas are a diverse tumor type which require often multidisciplinary management. GIST is a distinct entity that served as a paradigm for targeted therapy, and for non-GIST sarcomas, utilization of surgery and radiation, as well as chemotherapy is important. This concludes the presentation. Thank you so much for your participation.